Hello, for those of you who don't know me, I'm Alice Lichtenstein. I'm the Gershoff Professor of Nutrition Science and Policy at Tufts. I'm here to welcome you and thank you for joining us at this Friedman seminar. We'll almost start over again. This is the first seminar of the season, and we're really fortunate that it is also the Gershoff seminar, and this is to honor the founding dean of the school, Stanley and Gershoff. He was a real champion of the field of nutrition and of the expansive definition of the field of nutrition, and jump-started a lot of what we benefit from today. As far as today, we're very fortunate to have an exceptional speaker, Dr. Cheryl Anderson, who's going to share her knowledge and expertise. Having known and worked with Cheryl for many, many years, I'm really delighted that she has agreed to be the Gershoff speaker this year. Dr. Anderson is the founding dean of the University of California, San Diego's Herbert Wortham School of Public Health and Human Longevity Science. That's a mouthful. She also serves as director of the university's Center for Excellence in Health Promotion and Equity, and she has secondary appointments in the School of Medicine, and she holds the Hood Professor, or the Hood Family Dean Endowed Chair of Public Health. In addition to her leadership, though, at UCSD, Dr. Anderson, she's and her long-term research focus has been on the role of nutrition in the prevention and management of chronic disease, particularly cardiovascular disease, kidney disease, and diet-related cancers. She has been elected to the National Academy of Medicine, Council of Foreign Affairs. She's a fellow of the American Heart Association and currently serves on their board of directors. In addition to many of her activities, public health activities, she served both on the 2015 and 2025 Dietary Guidelines Advisory Committee, which is not an inconsiderable task. And she serves also as one of the deputy directors of the Journal of Diabetes, and she's on the editorial board of the Annual Review of Nutrition and Circulation. She's received numerous awards and has a very impressive publication record. On a personal note, I've worked with Cheryl in many venues, under many circumstances, and in some cases, some of them a little bit contentious. She has always impressed me as far as her commitment to getting the job done and also accepting alternate solutions when that's what had to happen. I really hope that in the future our paths continue to cross many, many times. The title of Dr. Anderson's presentation is Diet and Cardiovascular Health, Interplay of Biological, Behavioral, and Social Influences. It's a topic that I really think touches the whole school and the wide scope of our interests. So please join me in welcoming Dr. Anderson.
Sorry. Hello, everyone. Can you hear me okay? Wonderful. Well, first of all, Alice, thank you for that beautiful introduction. It has been a real pleasure in my career to cross paths with you and actually many of the faculty and others here at Tufts. I first want to say how honored I am to be giving the Stanley Gershoff Memorial Lecture. I've heard amazing things about the generosity of Dr. Gershoff, the character of Dr. Gershoff, and I hope that light will forever shine on him within this school for all of the good work that he's done. I'll start with the bottom line up front. So I'm here, as Dr. Lichtenstein mentioned, to give you an overview of diet and cardiovascular health. We know there's a biological basis for the pursuit of this association. We also have a behavioral component to it, right? Diet is a modifiable risk factor, and so how we behave around foods and our relationships with food will matter in this examination of diet and cardiovascular health. And then there's social influences that well that are at play. So today, I will make it pretty clear that diet continues to be a suboptimal level of a risk factor that we have within the US society. We also know that cardiovascular disease continues to be the #1 killer of people, and it's considered to be often excess deaths because we know that so much about cardiovascular disease is preventable. So let me dive right in. So I don't know how many of you look out for the January publication of heart disease and stroke statistics every year. I happen to be a part of this writing group, and you'll see that the prevalence of risk factors for cardiovascular disease is high, right? Diabetes or prediabetes affecting over half of US adults. We know that high LDL cholesterol is prevalent in over 25% of adults, and this leads to quite a bit of attributable risk for death from cardiovascular disease. In addition to the brunt of the burden, which comes from mortality, we also know that there's a lot of cost associated with cardiovascular diseases. In 2020 to 21, the annual direct and indirect costs were estimated to be over $417 billion. And furthermore, at every life stage, we see that there's a potential for increased risk because of certain behaviors. I'll talk today about diet, but we should also not leave the room without mentioning that physical activity and the use of tobacco is also critical in how people experience cardiovascular disease. So this is one of the slides from the Global Burden of Disease group at the University of Washington, the Institute for Health Metrics and Evaluation. And you'll see that the top 10 causes of early death and disability in the US, and I like to think about death as well as disability, right? Because when we can count deaths, we still need to keep a focus on the fact that the burden is bigger than just death. But you'll see here that the leading cause of death is clearly ischemic heart disease, and much of the poor health that Americans experience is driven by risk factors. Diet accounts for over 11% of early death and disability in the United States. When we look at the world, we also see that the global burden of CVD and its associated risks is not borne uniformly across the globe. We, in terms of behavior, see that dietary risks sit at the top of the prevalence when we look at age standardized disability adjusted life years per 100,000 persons across the globe. Now, trying to study this and having built a career where I've looked at diet and its association with cardiovascular disease is a tricky thing because often we're awarded our grants in 5-year intervals, right? Which usually isn't enough time for us to see cardiovascular diseases develop within populations. And so often we're approaching this through looking at diet as it relates to surrogate markers, and then we understand what those surrogate markers might mean for outcomes. In the case of blood pressure as a surrogate outcome, I think we have what might be the hallmark clinical trial that was conducted in this space. And that trial is actually at the heart of what we think about in terms of diet recommendations today. So I'll go through that one quickly because it underpins a lot of what I will talk about later. So when we look at dietary patterns and blood pressure and what it means for the risk of cardiovascular disease, the landmark study here was the DASH trial. How many are familiar with it? All right, very good in here at Friedman. So it was a randomized control trial, but a special one, right, where it was a feeding study. Everything the participants consumed were given to them by the study investigators, all foods, all beverages. There were 459 adults, 22 years or older, and they were in 4 regions of the country. The interventions were threefold. There was a control intervention, which looked a lot like the typical US diet. Then there was a slightly healthier intervention, which had more fruits and vegetables than a typical US diet. And then there was an intervention that they called the combo, which met all of the guidance at the time for cardiovascular disease prevention. The study went for 8 weeks, and the primary thing that they looked to see a change in was blood pressure. This was published in 1997 in New England Journal of Medicine. The design paper came out in 95, so it's been some years. Here's what was found in the DASH trial. They saw that that blue line, where you have the healthiest diet being fed to study participants, in 2 weeks resulted in a really significant drop in blood pressure. That persisted over the 8 weeks of the study and was a larger drop than happened with the fruit and vegetable enhanced diet or with the diet labeled as control. That said, since the 1990s, when the DASH trial was published, it's a feeding study. We can't really go around feeding every single person that we need to improve cardiovascular health for, right? So lots of other types of studies, observational and otherwise, have been done since then. And just last year, the conclusion, after a very rigorous systematic review process for the Dietary Guidelines Advisory Committee, asking the question, does a healthful dietary pattern reduce cardiovascular disease risk, came out with, yes, it does, and there's an incredibly strong association there. All right, so that's establishing the relationship between a healthy dietary pattern and cardiovascular disease risk. Now, what if we were to go a bit upstream, however, right? From feeding people or looking at what people eat into what does our food system do to support or get in the way of good cardiovascular health? Well, what is a food system? Well, a sustainable one is one that's going to meet the population's needs without compromising what future generations might need. And a healthy one is one that promotes and maintains a nutrient-dense dietary pattern and optimizes health individually and cross-culturally, right? So can we have a healthy and sustainable food system? I think that's an open question, right? We, in one of the science and policy reports for the American Heart Association, published this advisory, and this one was in 2019, about what it would take. How could we develop more of a socio-ecological model around diet such that the food system actually is one that provides a default option of healthful options for individuals? We also know, and thanks to Alice for her leadership here, that there's a lot of dietary guidance around what improves cardiovascular health. The systematic reviews are pretty consistent at this point. The observational epidemiology, as well as some of the additional feeding studies, suggests that we can recommend a healthful diet for cardiovascular health. We also know that, as many of you here study, that we need food policies and programs that are going to help us not only allow people to eat, to give them guidance about what to eat, but such that they have security in doing so, right? That people know that they can access healthful foods routinely. And then we also know that there's some popular dietary patterns, multiple paths to a healthful intake that align us with good cardiovascular health. When we think about what goes beyond the food system, we have to really think culturally about what's going on. And in 2020, this advisory was published, which really, I think for the first time, brought to our consciousness as a cardiovascular disease community in the writings of our journals, the potential for structural racism to be a fundamental driver of health disparities, particularly cardiovascular disease disparities. Then, of course, every 5 years, the dietary guidelines for Americans gets revised. This is by congressional mandate. It's happened since 1943. And we currently live under a dietary guidelines from 2020 to 2025 because the new one hasn't been released yet. We can talk about that in the Q&A if you'd like, which says that we should make every bite count. We need to think about having people follow a healthful dietary pattern across their entire life stage. And there's consideration for cost, there's consideration for culture, and we know that there are nutrients of concern, still a problem when it comes to added sugars, the total fats in a diet, as well as the amount of sodium in a diet. But in sum, we know what to do, right? I have just outlined for you a lot of data summarized pretty quickly around what it is that we should be doing for cardiovascular health. Yet, we have persistently low adherence to guidelines. So if you look at the Healthy Eating Index, which is a measure of diet quality that we use to assess how well what people eat align with dietary guidance, Americans are at a 58. Now, if you walked into this room and we gave you a quiz and you could score from 0 to 100 and you walked out with a 58, we'd say, not so hot, right? So we're not doing so well. Most Americans do not align their eating choices with the dietary guidelines. This has persisted. When we look across 2005 to our latest data in 17, we see it's been hovering right around high 50s, low 60s. Furthermore, it doesn't matter how old you are. We see that our youngest of citizens, ages 2 to 4, are at a 62. And then once we look in older adults at 60 or older, we see, again, in sort of the low 60s. So this is going to be something that we need to deal with if we're ever going to really accomplish good cardiovascular health. We know through the data that it's really important to adhere to the dietary guidelines. People who do, in the population samples that have been studied, have smaller waists, they have lower insulin resistance, they have a reduced odds of carotid atherosclerosis, there's a slower progression of atherosclerosis when present, and there's total CVD and lower total CVD and lower CVD mortality that occurs as well. So that said, what is going on? Why are our behaviors not aligned with the dietary guidance? I'm going to talk a little bit about behavioral intervention studies. I'll talk first about my own because I trained in the earliest part of my career at Johns Hopkins with the group who did the DASH trial. And I was stargazing, really, having read all of that through graduate school. And we designed together a study, and this is probably where most of you know me, is from my work in sodium. I designed a trial that was focused on the maintenance of the guidance around dietary sodium at the time. So this is SPICE trial, a feeding study that was followed up by a control study, by a control trial. We recruited 40 adults in Baltimore. They were assigned to one of two groups. The intervention group got a behavior change intervention for sodium reduction. We used spices and herbs to put flavor in where sodium was removed. The control group received a pamphlet from the CDC and were asked to go with God. Followed them up for 20 weeks, and we looked at urinary sodium excretion as our primary outcome. So here's what happened. During the feeding component, we saw very similar results to what happened in the DASH trial. You give people the food, they eat the food, and you see the expected reduction in sodium as measured through 24-hour sodium excretion. When we looked at the behavioral intervention component, which happened from the end of feeding through the following 20 weeks, we noticed there was a noticeable difference. If you look here at the 40 millimole per day difference, which is about 1,000 milligrams of sodium per day difference, highly significant between those who were in the intervention group and those who were in the control group. That said, my question was, could we get people to adhere to the recommended amount of sodium? So, what do you see and what do you wonder? Our goal line here is the green line. What is this? This study got so much attention. Reporters were calling me left and right. What do you see here? Yeah. So here's what really bothered me is why aren't people able to get to goal? Right? So we fed them. They were there. And then we're here in a behavioral intervention and they aren't able to stay there. And I just remember sitting with my mentors at the time and we're talking this through and they're like, this is great. This is exactly what we saw in the trials of hypertension prevention. This is exactly what we saw in the trials of the prevention of hypertension. They're super creative. And, and then I said, I've seen this before. I saw this in the diabetes prevention program. After many months of intervention, everyone's doing better, but they're not at the initial goal line. I saw it in a premier trial. Once again, right? They're sitting above that line that we want them to get to. I saw it in the weight loss maintenance trial. There's this check mark pattern that's happening. And how do we get through this? Look ahead, right? The ability to get people to goal it's there, but we can't keep them at goal for extended periods of time. So it actually changed the trajectory of my career. I decided at that point that I was really going to hone in on trying to make a difference on some of the things that happen outside of the ivory tower, right? We bring people into our research settings. We have beautifully designed interventions. People are able to hold on for the time under study, and then they go back into their everyday lives and things fall apart. So I'll give you this analogy because it really hits home for me. Comes from the archives in North Carolina around health equity research resourcing. If you walked up on a pond and you saw one dead fish, you'd probably wonder, what's up with this fish, right? But what if you looked across the pond and you saw lots of fish dying in that pond? You're going to start to think about what's happening in the pond. What happens when you see it all across multiple ponds? Now we're starting to think about groundwater, right? And when you look at the CDC maps, which I didn't put in my talk today, but you've all seen them, right? The CDC prevalence maps, heart disease, obesity, hypertension, diabetes. You even saw it during COVID. The patterns are consistent. It is not random where or how things happen in this country around mortality and disability. So I think it's time for us to take a really serious look at structural, systemic, and institutional factors that are impacting cardiovascular health. This is largely thought of as the social determinants of health. What are some of the upstream factors? If you look at my original diet to risk to surrogates to cardiovascular health, food system, right? Now let's go even further up and look at what are some of the things in our communities that are playing a crucial role in determining health outcome. When it comes to diet, there are a couple of things that are mentioned, and the paper by Ann Thorndike, who's just up the road, right? Where the dietary advisory really covers how do we ensure there's nutrition security, highlights these 5 areas for thinking about diet. Is food available? Even if it's available, is it accessible? Beyond accessibility, can people afford it? And then is it used? And is it used in a way that's stable and sustainable, right? I think these are some of the determinants of whether or not people are going to eat well. Furthermore, in Ann's policy statement, you see that so nicely outlined. And we also have a burgeoning science around implementation. How do we think about dissemination and implementation of what we learn in our academic settings such that it's possible within community settings? I'm going to do a quick pop quiz. How long does it take for findings from university studies generally to reach communities? Throw out a number. How long does it take? 12. 17 years. It takes 17 years for our studies to reach community settings. That is way too long, and we have to do better, right? So how can we have impact, right? How can we get beyond the work that we do here in our laboratories such that we can make a difference in the lives of everyday citizens? And I want to just pause here and say this is a conversation that is happening every single day right now, right? The value proposition for what we do, the brand of what results from the work that happens in the academic world is top of mind for everyone, right? We are thinking about, are people going to go to college? When they go to college, will they stay in college? When they come out of college, will they remember us as a positive place in how we've impacted their lives? Are they going to fight for Tufts? Will they fight for UC San Diego because we're having such a tremendous amount of impact on everyday lives for people? So what do we do that's going to be impactful? Well, Tom Frieden, who many of you might know from the CDC, was a director of the CDC and worked in the New York City Department of Health for quite some time, put forward this possibility of a framework through the health impact pyramid. So you see here that, of course, we can counsel and educate people. We have clinical interventions. We talk about taking your medications for risk factors for cardiovascular disease. We can have protective interventions where we screen people, we do procedures. We could also change the context, right? Make it easier, make a default choices, ones that are healthier for people. And then at a foundational level, really think through some of the tough things: poverty, education, affordable housing. Now, when we're working at the top of this pyramid, which is where I would dare say many of us are, that's what my behavioral intervention study is doing, we're not having the biggest impact. Yet, trying to have the largest impact requires us to do our work differently, right? How do we work here at the base of this pyramid such that we might truly have people remember what we're doing and hopefully have things stick and bring that HEI up? So let me walk you through this framework that I literally wrote down one Saturday afternoon as I was thinking through some things that we were struggling with in the Dietary Guidelines Advisory Committee, which I guess my tenure there was 2023 through 2025, through December of 2024, so just before the 25 came. So it turns out there's a lot going on here, right? In terms of diet and cardiovascular health, I'm thinking about the healthy eating index. I'm thinking about whether or not we have disparate health or if people have really great health. I'm thinking about are foods available all the way across this continuum through being sustainably um, available, and then what levers can we pull in order to um, have people optimize their cardiovascular health through this cornerstone of diet. So let's start at the beginning. We're currently at 58 with regards to healthy eating index, right? But where we really want to go is probably to be in the 90s, right? You came in to take a quiz, 0 to 90, you want to leave it in the 90s. All right, so we want people to be higher on the healthy eating index. What we also need to have happen is the nutrients of concern for overconsumption, we want to see those decrease. And as we go up in the healthy eating index, we'd likely see significant decrease there. And then there are nutrients that we have concern for underconsumption, right? The healthier nutrients, potassium, for example. And we want to see those go up. Then we want to think about how do we move from health disparities being commonplace, right? Those differences that we see in the maps that the CDC puts together routinely, to a place where we really have justice in healthcare. Similarly, as we go from a low healthy eating index to a higher healthy eating index, would likely be able to move ourselves across this security trajectory, right? Not just are foods available, but there's a stability and a sustainable way of using them. And then the levers that we can change line up with a lot of what we think through in fundamental public health practice. So there's what happens to me at the individual level. There are going to be biological and individual level constructs that I come into the world with, right? But then my family life, my interpersonal interactions, my social settings, the policies and structures around me are also going to matter. So I think about this as, sort of your individual level characteristics being the seed, but everything else around you is the soil that either allows that seed to flourish or it dies. And we can pull levers at each of these positions in order to optimize cardiovascular health. So this for me is sort of my operational principles when I go in and I think about my work. Well, what are we going to do here? I love this quote from Dwight Eisenhower. Farming looks mighty easy when your plow is a pencil and you're 1,000 miles from the cornfield. So what have I decided to do? I'm going to throw down that pencil, right? And I'm going to go out into community settings because I feel like this is an opportunity for us to really think locally, act globally, and work with some of our partners. So I've been working more with a partner in San Francisco, which is Project Open Hand, around our Food as Medicine initiatives. We have Mama's Kitchen down in San Diego, which also serves medically vulnerable individuals. And then a great chunk of my work happens with the United Women of East Africa in San Diego, where we think and talk through what happens during forced migration and the changes in dietary acculturation that happen along the way. I can't get into all of that right now. I want us to have time for discussion. And so I'm just going to share with you a recently funded study that we call KIN. It's our community driven research incubator. And our whole goal is to advance food justice through partnered community driven research. This study is funded through the Robert Wood Johnson Foundation and American Heart Association's Health Equity Research Network. They've put $20 million toward advancing health equity through these community driven research centers. So, the vision here is that we have flipped the research paradigm. So, this idea that we're going to stay in the academic tower and we're going to pull people up to La Jolla and we're going to do all of our fancy things and then we're going to publish it in, I don't know, name it American Journal of Clinical Nutrition, and then we expect magic to happen, right? We're flipping the paradigm and we're going out to work with community-based organizations. Our mission is that we're going to have a comprehensive place-based research to action food and nutrition research program that will be doing things very differently, but it will complement the traditional ways of practice around nutrition research. We're not saying throw it all out. We're saying let's be additive and try a new way. Our focus is on equitable land use, using our knowledge to make sure that people have fresh, healthy, and culturally appropriate food and water. One of these days, I can tell you all about our water situation in San Diego, where we've got sewage flowing down from the Tijuana River into one of our neighborhoods. People can't open their doors, they can't drink the water, and they show up in the ERs in disproportionate numbers at this time. So water's a big deal for us. All right, so the first component of this is we're flipping the paradigm around who leads research. So typically, when you go in for a grant, you have a conversation. Who's the best person to lead this grant, right? You've got to have this massive, usually NIH portfolio of research. You need to have maybe lots of years in service to do the work. And we've decided lived experience is going to be as important as trained experience in this study. So here's our PI team. I happen to be the overall program director. I'm a person who's been identified as having lived experience as well as trained experience. And I'll tell you a little bit about my lived experience shortly. We have individuals who work in community settings. Our key partner is the YMCA of San Diego. We have our Center for Community Health, as well as something called the Childhood Obesity Initiative that has been active in San Diego for over 20 years. And some of us have fancy degrees, some of us have fancy life lived experiences in this space, right? And we consider this entire partnership equal. Everyone's listed as a co-PI. The heart of our grant is the people who form our community council. And some of them are photographed here. They have essentially been working with the San Diego Department of Public Health, with lots of entities in our university, to help us think through how do we have sustained impact when our studies are done at the university level within the San Diego community. So they are a critical part of this grant team. Our aims are threefold. We have this beautiful schematic that I hope you can see, but if not, I'll break it down for you shortly, that emphasizes the three big components and all of the various inputs into those components. So first, we've created a community granting program. So when the money comes into the university, we immediately give it over to the community. And that granting agency helps us to develop a peer-reviewed program that members of the community write their grants. They submit, just like we would submit ours to a sponsor. It goes into this sponsorship pot, and it gets reviewed by community members to decide what are the priorities of the community that should be put forward using these funds. We, at the academic side, have what's called a methods core. And typically, right, we academics, we run into the community when there's an opportunity. We say, hey, we'd like X, Y, or Z from you. Can you help us? Opportunity ends and we're out, right? We're flipping the paradigm here. They have the money. They come to the university and say, we're going to pursue this project. Now we'd like to ask you for X, Y, or Z, right? So flips that paradigm. And then we have a postdoctoral training program, and each postdoc has a lived experience mentor and a trained experience mentor. So they are being advised the entire time of their studies by someone who's walked the path, as well as by someone who's sat in a classroom to try to understand these various things. So this is where this is what we're currently doing. It's a 5-year study. We just finished year 1. We use a framework called the EPIS framework, where first we explore and prepare so that we're doing all of the early work, and then we implement and we think about sustainability. So what have we been doing around the sustainability piece, which is something that we're thinking about right now up front so that we can not be, caught on our back feet in year 4. We've really been thinking a lot about the momentum that was required to build us toward being able to get this major investment. So in 1987 was when the university made a commitment to doing community health work through our Center for Community Health. We had, before the medical school was even started in 1966, we had a Department of Community Health, which had physicians in it who worked with community partners to try to ensure good one-to-one person health, right? So medical health. But this commitment in 87 was about population level health, right? How do we work with people hundreds, thousands at a time, not just in the one-to-one interaction? Over time, we have stitched through small intramural grants, through small foundation grants, efforts together to really keep the momentum around this commitment for doing community health. And then finally, in 2023, we saw this possibility of a $20 million investment, and we knew we were ready, right? This isn't something that we just started thinking about the night before the proposal RFA was on our desks. So here's what we'll do over time. We've just started with our first RFA, so the grants are now the grant proposals are now coming through, and we're leveraging partners for impact. So on the local level, we're thinking about our Health and Human Services. That's our San Diego division. We check in with our county board of supervisors. We have a strong collaboration with the American Heart Association's local chapters. We work with our funders. We have a number of philanthropic groups who provide sponsorship for work, and we're lock in step with some of their priorities. We work at the state level as well, going all the way up to Sacramento, which is our state capital. We have very strong ties with our advocacy groups. And on a national scene, we've also been working with the Center for Policy Initiatives. We do quite a bit of work around the Farm Bill, and we have collaborations with CDC, USDA, and very active roles in what's going on at the National Academies of Medicine, as well as some of our other professional societies. And then our network really helps us to think about, again, this flipped approach to how power is perceived in who does research and the impact of the research, and developing a playbook for how we drive action within communities. So the innovation here, as I wrap up this new study that we have, is that we have lived expertise and trained expertise, faculty and involved investigators in the program. Over 25 of us work together. We meet weekly in subgroups, and then we meet bi-monthly in our larger groups. There's a lot of diversity in our backgrounds, the types of education that we've had, the kinds of lives that we've lived, the subject matters that our expertise lie in. And we have over 400 community partners, which is a big deal. We're really saying to San Diego, this is for you, with you, and about the things that you care about. I don't have time today, but we did a campaign prior to starting this study where we asked people very diligently, what matters to you most in San Diego? The top issue was housing, and the second issue was food. We decided to pursue food in this grant because that's where much of our expertise is, but housing remains for us, sort of top of mind. But our partners are on board, and that's how we're going to do this. So that's the bit of my research that is supporting where it is that we currently are with diet and cardiovascular health. Because I know there's students here, before I close out, I just want to take this opportunity to tell you some things that I Three things that I wish I would have known when I was in your shoes trying to pursue this career in diet and cardiovascular health. So that's me, where the arrow's pointing. I think I'm probably 3 years old, kind of a tall 3-year-old, but I'm three there with my aunt and uncle, my two of my siblings, and two of my cousins. And the first thing that I want to tell you is this is me and my dad. My dad, I call him the original organic farmer. He worked for his entire career as a chemist in one of the sugar laboratories in Florida. And he, as a hobby, has always had a small farm. And school doesn't teach you everything. So my dad and I will often go out into the farm, and this is him teaching me about a plant called sorrel. It's also known as hibiscus. If you're from the Caribbean, it's a drink that gets made in the holiday season. And his garden is just thriving here, and I'm trying to understand, like, what happened from seed to product here. And I also, as I look across everything that he's doing, I learned so much, not just about, how do you bring something from a tiny idea into a product, but you think about when you move the peas, what happens to the onions, right? When you move the bananas, what happens to the jackfruit? What needs shade? What needs more water? What needs more sun? And so, this idea of an ecosystem where all are allowed to thrive because of biodiversity is something that I've just learned through living and watching my dad in the garden doing. So, keep in mind that there are many, many ways to learn, and some of it will happen here in school, a lot of it will happen outside of the walls of this place. Lift as you climb. So for me, I've had from the time I was a toddler, a really supportive family. I grew up in a town where life and health were often impacted by young women having too early and too frequent pregnancies. When the HIV epidemic hit in the 80s, it just completely devastated our town. We had a lot of migrant workers coming in from Haiti. And yet and still, as a young girl who had aspirations to just be something bigger than I'd ever seen before, there were people there helping me to make that lift to the next step, to go to college, to think about things beyond an undergraduate degree. And I just encourage you, it doesn't matter what stage you're in, as you're moving toward your goals, bring others along, right? It takes sometimes so little of us to do a kind action, and it can mean the world to someone else. And then lastly, looking isn't the same as seeing, right? We can direct our eyes at something, but to really perceive and observe requires a different kind of focus. And so don't assume that you've seen it all when all you've done is to look at it. And then lastly, I'll share my favorite quote before I closed out. And this is by Maya Angelou. I'm convinced that courage is the most important of all virtues because without courage, you cannot practice any other virtue consistently. It is only with courage that you can be persistently kind, generous, merciful, honest, and fair. And if she were here with us today, I would say also to do the kind of work that we're doing in nutrition today, it requires us to be quite courageous. And so, with that, I will say thank you for your time, and I look forward to your questions.
Well, thank you. And I think, as you can tell from the response, you really struck a lot of chords. So, what I would like to do now is invite individuals in the audience to ask questions. And I believe we have some mics that are going to be passed around. But if not, just stand up and shout your question. And I certainly expect that the Gershoff scholars will have some questions already lined up.
And it's all fair game, right? You can ask contemporary issues, science issues, career issues. Sam.
Thank you. That was an awesome talk, and congratulations on the Kin Incubator. It sounds like a really exciting opportunity. And my question is actually based off the Kin Incubator, and it's definitely going to have what it seems to be a substantial impact in San Diego. And I'm wondering, do you foresee it having an impact beyond just San Diego, and what that would be? Is it nationally, internationally, or do you feel that universities need to do this in their own local communities?
Yeah, that's such a fantastic question. Thank you. So we have, in addition to our kin team, we've established something called our next of kin. And it's with this very question in mind, right? What is it going to take for us to, in addition to kind of, this pursuit of um, diffusing power a little bit around research and prioritizing what's truly important for communities, such that we don't just show up and see what's happening. We don't just show up and do things, but when we're finished, we're actually remembered for what we've done, and people are wanting to maybe further other agenda with us. I think that's a concept that every town in America might be able to wrap itself around. I think it's also something that, if we're honest with ourselves, has been happening on the global scene for a long time. So, for those of you who work in an international context, you will see that this idea that it's not always about what you have, but what you have around you is always at play, right? Because in lower resourced environments, we aren't necessarily having um, everything that we need to move an agenda forward. And so people tend to pool their resources a lot better than we do here. And arguably, impact is bigger because you have more invested stakeholders from the very beginning by necessity. And so I think this work is likely in San Diego for sure, through our 400 partners, to be very well um, sort of spread. And as we begin to publish from the work and do the roadshow of the work, hopefully conversations across different municipalities will occur too. But I just want to say, this is globally. This is a concept that I think people have been using for some time.
I think I saw Dr. Dwyer's hand up.
Hi, Cheryl. That was a great talk.
Hello, Johanna.
Going way back to the beginning
Yeah.
and Dash, and I know you were at the beginning in Dash. I've always been puzzled by the blood pressure lowering being bigger than could be explained by sodium alone, and I know you've done a lot of studies with sodium. What do you think, other than sodium, is involved there?
Absolutely. So thank you for asking that question. The point that I didn't make as clearly is that, when you look across the literature, decades of literature on diet and cardiovascular health, you see a progression in how we've approached the topic, right? We've gone from single nutrients, foods and food groups, maybe different types of dietary patterns, and now I'm suggesting that maybe we think about food systems too, right? So the question you're asking is about a single nutrient, sodium alone. This was not a question of, could sodium reduce blood pressure? The question was, could a healthy dietary pattern reduce blood pressure? So in addition to the action of sodium, you've probably got magnesium, calcium, right? Potassium at play here. What I find striking is that the reduction is bigger than you might actually see with a pharmacologic agent as well. And so, in a context where you know that people are consuming the diet, you're measuring adherence, you're feeding them what they are being asked to eat, you see these large drops in blood pressure that have been repeated. So, it's a replicable finding. And when you combine that original DASH study with a lowering of sodium, so the 2 by 3 factorial, DASH or not, 3 different levels of sodium, you see even lower amounts of blood pressure when the pattern is healthy and sodium is addressed. So it's a whole pattern impact versus sodium alone.
Okay, Dr. Taylor, I see his hand up.
You indicated specific HEI values that were paltry. Can you, in the best countries, which the highest HEI values, what are they, and are they different for rich and poor, and especially among the elderly?
Yeah, so I'll first say that the Healthy Eating Index is a concept that measures alignment with our dietary guidelines for Americans. So it's an American-centric index. But I think your question around where do we see eating patterns being more healthful across the globe, and what does that mean for overall outcomes? So I'll turn again to a bit of a paradox, right, in what we call acculturation, dietary acculturation, where sometimes you look across areas that are considered lower resourced across the globe, where foods have not yet the food system has not yet been infiltrated by what we think of as associated with higher economies, foods that are more processed, foods that are easier to access because they've been pre-prepared. And in places where diets are sort of just more natural, we find that the resultant health impacts around cardiovascular health are there. What happens, however, is you have this competing risk from infections because infrastructure is often not there to protect individuals from things that might come through because of other practices around infection control. But the relationships do hold in populations. Sometimes people try to say, well, the life expectancy isn't as high as one might like because, again, there's this competing risk of death that one needs to take into account. With regard to HEI, a lot of things would have to change. I think if we were able to make healthier foods more accessible, have them be more affordable, have people actually know what to do with them once they get them, cook them well, or right treat them in a way that's flavorful, that doesn't add to nutrients of concern, then I do think we could get the HEI up at least to the 80s. But we don't currently have that backdrop in order to make that happen.
Okay, well, one of the things that I have been championing is having mandatory food and nutrition education in the school system from K to 12. We have, with this part of the agricultural bill, the school lunches need to conform to both the dietary guidelines and the DRIs. However, there doesn't seem to be anything going into the school system. I'm wondering, within your community, where much of the curriculum is determined by the community, is there any way of, at an age-appropriate level, introducing that so that the seeds are there, the context is there? So we spend so much time, I know you on committees, I committees with all these guidelines, but if people don't understand what's behind the guidelines. So do you think there's any opportunity for you to initiate that within the community?
Yeah. So, our childhood obesity initiative is laser focused on this. And this is why, when we think about the movement on the HEI, we also have to think about policy efforts because you can't just walk into a school one day and say, here are my data, time for us to do something differently. It's not going to happen that way, right? It's going to take layers and layers of stakeholder buy-in, et cetera. And so what our childhood obesity initiative is doing is it's building this grassroots effort where our city council members are well involved in what's going on. We have the ability to, take things to Sacramento, stand at the podium when it's time for legislation to get made for people to understand this. We're getting some traction. So independent schools, for example, are understanding more so the importance of K through 6 education. In the cases where the independent schools go from K through 12, we're seeing adoption of not just kind of nutrition talk, but healthier lifestyles talk. So including physical activity, including sleep, including food, including tobacco, use, conversations with our early age citizens. And so, yes, I do think that's absolutely critical to the to the journey. And we all use education as the control group for our studies. So it's necessary, but it's not going to be sufficient, right? We want to ensure that people know what it is they're supposed to do. We all certainly keep doing the studies over and over, but we have a good sense of understanding of what it is that we need to do. So I think tackling some of those harder foundational issues is going to be really, really key.
We have time for one more question. Okay, Yeah. Go for it. Okay. I'm sorry if I didn't see you before I asked my question.
Oh, not at all. Thanks for this talk. So, there's a whole lot of distrust in science in all sectors of work, in vaccines and climate science. There's a lot of people willing to tell everybody that you shouldn't believe what the scientists and the researchers are saying. And I've had a question that I've wanted for years to ask somebody who's both expert in sodium and who cares about public affairs. So you seem to be the person.
Get it out because we're running out of time.
which is it possible to use diet blood pressure connections to educate people about how science works in a way that builds trust? In other words, is the blood pressure response to dietary change so clear and so obvious that you could develop a little curriculum for lay people to get groups of people trying to change their diet and measure the effect on blood pressure?
Yeah.
Or is that naive?
No, it's such an interesting concept because blood pressure is often dubbed the silent killer, right? And so people may be experiencing increases in their blood pressure and they have no idea. You don't feel any different. It isn't until your blood pressure is extremely high. Maybe you start to see floaters, right? Or you have an event that you realize something is going on. So this idea that you could take an obvious exposure, a common source exposure like diet, and link it to something that is silent / invisible, and maybe with our new wireless devices or some kind of fun tracking mechanism, begin to craft a story around, look at the response, because it happens relatively quickly, right? 2 weeks to what it is that you're eating, I think could have some some play here. Now keep in mind that it matters where you start when it comes to changing your blood pressure. So without disclosing too much PHI, right? For me, if I were to start lowering sodium for blood pressure control, I'd be flat because my blood pressure is already kind of low, right? But, for some of my family members, we won't give names, they could use maybe, right? A little bit of someone called me and said, the doctor says I have prehypertension. I don't add any salt to my food. I said, let's talk about the Zatarans in the cupboard, right? So that kind of thing I think could be really, really helpful. But again, it's less ivory tower and more pragmatic in people's homes every day, out in community, trying to help get things done. Great question.
And it turns out that we do have a little more time. So, Dr. Rogers.
Thank you. Okay, I'm going to go back from the broad policy questions, but you showed several graphs of the control group and the intervention group, and the outcome was urinary sodium, and there was one on blood pressure and stuff. In more than one of the ones you showed, the control group and the treatment group dropped. And at the end of the trial, the control group shot back up, and the treatment group went up, but not as much. And there was a persistent difference. And I want to know what was going on in that end measurement when the control group that got the pamphlet also achieved significant improvement.
Yeah. So in 2 instances, in the weight loss maintenance trial and in the SPICE trial, you see a lowering of sodium. In the weight loss maintenance trial, it's a lowering of weight, and in the sodium trial, it was a lowering of salt. That's because in the beginning of those 2 studies, everyone's being intervened upon. And the question is about maintenance. So once you've gotten people to goal, do they then continue to be at goal? So that's what's going on there. The other really cool phenomenon that those of you who do clinical trials will notice in your own studies is there's this placebo effect that all of a sudden people get in a study and you tell them you're randomly assigned. You're not sure if well, in diet studies, they often will know if they're in the placebo group or the intervention group. and they just start doing things better. You're like, are you working against me here? What is happening? But yeah, so often there is this kind of just healthy study effect that's going on with people who aren't in the intervention group. It doesn't persist; it usually goes away. But that check mark that's so striking is usually because it's a maintenance study.
Any more questions?
Hi, thank you so much
Hi,
for that presentation.
you're welcome.
It was excellent. I wanted to ask about the KIN. Oh, thank you so much. I wanted to ask about the KIN program. Since what makes it unique is the approach, how are you measuring the impact of the approach itself rather the interventions that the communities are putting in place?
Yeah, it's
Thank you.
tough. It's really hard to measure, to do process measures, as you probably all know in your own research groups. So we have a story campaign. We're working with the Indigenous Futures Institute, where storytelling and documentation is really key. And so there's that, so that it's not just about trying to figure out what the right metrics are, even though we're doing that too, but we're also hearing people's own words around what is going on in their everyday lives as a result of their interactions with what these studies that are going to take off. The other thing is, because we don't do the research ourselves, we have the community-based researchers do the research themselves. They are coming up with what are the metrics that are important for shifting and acknowledging, so that we know that things are better. And our team at the university is there to consult. So turns out right now, we're going through our first RFA process. We'll see what they determine to be their priorities. They'll come to us for expertise, and then we'll say, and by the way, it'd be very helpful, we think, if you would measure X, Y, or Z, right? Because sometimes in academic community partnerships, we overcorrect. We don't want to be overbearing. We don't want to be dominant, but we leave our science behind. And so we don't want to overcorrect, right? We want to bring our best scientific thinking, and we want community priorities to be at play. And so the two things can coexist, but we haven't yet done our very first set of projects, so we'll see. That said, for us at the sort of academic core, we're already looking at like how much interest is there in the granting programs. What size awards do people more so go for? What are the topics consistent with what we learned through our sort of early formative work? So we're tracking on a lot of different things. Is the COI really kind of being called into like the efforts that the COI is working on? For example, we were painting, the COI was doing a report out on painting pedestrian crossing signs in school zones, right? Are those things coming up as community priorities, or is it that people want to cross the street so they can get to better food? Like, what's happening? Are the connections being, so we're keeping an eye on all of it.
Okay, one last question, two last questions. Yes. And this is very, yes, please. And this is very impressive because it's a real indication of how what you've said is resonating in the community that's sitting here.
Thank you so much for the presentation. So I've been doing international public health and nutrition for the last 25 years. And as you said, internationally, this kind of approach of sort of community-led research and program design has actually been happening a bit more than perhaps here. So it's something I've grappled with for a while, and I fully I'm on board with the approach, and I think it's very important. At the same time, as you pointed out, with the social determinants of health, socioeconomic or social determinants, like larger policy environment, is so important. And so I sometimes worry, and I'm curious what your thoughts are, having the community lead, they're not necessarily changing the policies that
That's
have
right.
so much influence.
That's right.
And affecting food systems at large. So I'm just curious what your thoughts are on that, because I think that's a challenge.
Yeah, so our partnerships include the community-based organizations, people who work and use services there, as well as our governmental. So our city government, we have our city council person, we have the chair of the commission involved. We have individuals in Sacramento, right, at the state policy level involved. And we're constantly feeling like we're not doing enough, right, when it comes to policy shifts, because it doesn't matter how much data one generates if those data cannot be applied to make a difference, right? And so I think your point around just how much is enough, I don't think we can see enough. But in addition to the presence in San Diego, I think for us, we're fortunate in that the American Heart Association and how we work as with our professional societies, American Society of Nutrition, right? They have tremendous lobbies that happen in individual states where they have local offices. It happens in Washington. There's, Lobby Day. There's used to be You're the Cure. It's now Heart Powered. But there are all kinds of ways that advocacy happens. I personally think, for my tenure as founding dean, there will be two things that are highly significant. One of those two things will be the establishment of an advocacy lab for our school. We don't know how to advocate well in academic settings. And I do think the conversations that we're having right now in America about the value of higher education and this movement towards decimating us is largely because we haven't told those stories very well, right? And so I think as students train, in every layer of training, there should be and this is why we do what we do. And this is how people know that we have been here. This is how they remember the work that we're doing with them about things they care about. And so hopefully there's all of that happening within the broader context of the work.
Hi, great talk, really great talk. So you mentioned that that there are like items in our diet, in our what we consume that really important. Like this is well known to improve your cardiovascular health, the consumption of potassium, and to improve diet quality. On the other hand, there are factors that you mentioned, to reduce the overconsumption of these foods. Some of these foods are ultra processed or processed. Do you think, what are their role in improving the diet quality? Is it because they're more affordable or because of the hyper palatability of these foods?
Yeah.
And how to mitigate this?
Yeah.
To improve this? Yeah.
Yeah. So not an easy question, right? Or else we'd have that all fixed. In fact, you might see in the next months or so a movement toward just saying we're going to get rid of ultra processed foods. I don't know like where the Health and Human Services is heading with this. But that said, processing, as you all know, is important, right? We can't get rid of all processing. We have to minimally process some things. Processing for what purpose? So is it so that you can't eat just one? We remember those campaigns, right? Is it in service of overeating? Is it in service of reaching a bliss point such that, again, you eat more than maybe you would have otherwise? Is it in service of allowing us to eat our vegetables and our fruits, our beans, peas, lentils? Like, what is the processing in service of? And I think right now there's been an over-reliance on processing for simple overconsumption of things that tend to be saltier, fattier, and sweeter. And so shifting us in a direction that is where we have a food system that, and a demand, because if consumers don't demand it, people aren't going to produce it. Think about gluten-free, everybody. Has there ever been a dietary guideline about gluten-free foods? Never. Do you see it everywhere that you go, in the store, in restaurants, etc.? It's everywhere. It took off. Consumer demand was built for it. Celiac disease prevalence did not go up, but people have intolerances and sensitivities, right? So there's a lot of things that we could do better, and I think lessons that we can learn from some successes that would help us have a healthier set of foods available to America. And I'm not up here saying don't process anything. That's not going to work either. But I do think there's a healthy place that we can all meet.
Such good questions. I
They
hate
are
to
good
cut it off,
questions,
but I
yeah.
think after this, the dean will come up.
I know I'm standing between everyone and lunch, and thank you so much for spending so much time with us. My name's Cecilia Gerard. I'm with the Food is Medicine Institute, based here at Friedman.
Yes.
It's
I
so nice to
remember
meet
you.
you.
Nice to meet you too.
And I love the way you graphically represented the large gap between the health disparities and health justice that we have currently in the United States. And while I heard you mention food as medicine in your presentation, I wanted to hear your thoughts on recognizing that currently these interventions, which address the affordability, utilization, accessibility concerns that you outlined, recognizing that they're a patchwork right now and funded only in a few instances, few constrained instances. If we were able to accelerate it, how far could we bridge the gap?
Oh my gosh, did I plant you? Did I plant you? So, Christopher Gardner and I just finished a food as medicine pilot study around heart failure, people who have heart failure, and diets that would be important for their sustained health once they come out of hospitalization. And we were looking at our findings, and I said, Christopher, wouldn't it be fun if we mapped our findings to this concept that Anne put forward in around availability, affordability, accessibility, use, stability. And so we did that. We're like, how many people did we solve through our food as medicine provision? We call it's healthcare by food is the more global name, right? Because food as medicine within our community has all kinds of it lands differently on people, but think about healthcare by food. So we mapped sort of, the fact that we were able to make food available to everyone, 100% hit there, right? Just because it's available, could they get to it, right? Because if you are trying to do a home delivery and people are unsheltered, unhoused, unstable housing, do we hit the mark there, right? So for the majority of people, yeah, we hit the mark almost every time. But we did see where it starts to fall apart if you're moving from X place to Y place, or you went from one family member to a friend's kind of thing. And then what happens around availability, accessibility, now affordability. You get rid of that concern as well, but the cost shifts. So someone has to pick up that cost, right? In our case, the Rockefeller Foundation is picking up the cost, but someone has to pick up the cost. And then, just sort of, so I think it's such a beautiful component of this kind of work is, even though it's not explicit when we say we're doing a trial on, the provision of, in our case, it was medically tailored meals, but what we're seeing is that we wrap it into all of those other foundational things that we know to be true, and we solve some of those things too.
Please join me in thanking Dr.
Okay, first I just want to take a moment and thank Alice, who is our Gershoff professor here at the Friedman School, for your time and effort, always putting this beginning of the year memorial lecture together. Thank you so much, Alice. And I also want to acknowledge and thank our Gershoff scholars and former scholars who are right here in the second row, who do their work in honor of Stanley and, of course, to advance science and policy worldwide. Thank you for all that you're doing. And now I want to take a minute to thank Dr. Anderson. Cheryl, thank you so much for being here as a fellow dean. I know it's hard to get away from home, but really appreciate you coming. Your work clearly resonated with all of us, and you really, I think, covered everything we do here, from science at the nutrient level all the way to community and global thinking around structures, around systems, around how we have really engineered our society to serve some and not others. And justice is really, I think, where most of us in this room really place a lot of our emphasis, despite the fact that we might be doing really focused work. We're thinking about that every day, and you really brought it to light for all of us. So we're so grateful that you came and kicked off the year for us with this memorial lecture and all your scientific contributions, and also sharing about yourself. That's really important in giving the students and all of us who are still learning and growing in the audience something to hold on to. And I think the really important three things as takeaways are going to stick with all of us, and definitely me as well, as I'm continuing to lead, but making sure that everyone in this room and everyone in our nutrition community is being pulled up, because it's going to take all of us to make the kinds of changes that we're all focused on right now. So we will not make you put this in your luggage. We're happy to ship it to you. Okay, but having a plaque in honor of coming today. And thank you so much.
I will say,
thank you.
I will say, first of all, Chris, thank you. I do feel, across you, Johanna, I see student faces that I recognize. When Alice calls, it's a different level of consideration. And so you all have such a great resource here in all of the work that she's done, the impact that she's having across the country, and the friendship that I've been able to strike up with so many of you. It's been wonderful. So coming to Tufts to me felt like something that should be prioritized in spite of all that's happening. So thank you.
Thank you so much. So we have lunch in the cafe, and we have a tent outside. Despite the fact that it's not raining, we will be sheltered out there. So please, everyone, join us for lunch. Thank you so much for being here.